my chat box back up. So hello, everyone. We're going to go over Chapter 18, Cardiovascular Emergencies, and this is going to be for both classes, the Advanced EMT along with the EMTs. So naturally, EMTs, you're going to find out a little bit more information tonight than what you would if you were using just your book. You're not going to be tested on anything that is above your scope, but this is good information to go ahead and have. And so we don't want, we never do a throwaway lecture ever. So I tell my children all the time that you can learn just as much from the doctor in the room as you can a janitor if you just listen. So without further ado, we're going to go over kind of the not so inspiring parts of the cardiovascular system. What that means is we're going to go over our A&P first and then the pathophysiology behind it. We're going to even discuss your medication and how that's going to react to your cardiovascular system, along with all of your signs and symptoms and management of specifically your chest pain, cardiac arrest, ACS, and then all of these that are noted here, all the way down to hypertensive emergencies. So reducing cardiovascular deaths. This is such a big deal. The AHA estimates that pretty much one person has an acute myocardial infarction or an AMI, otherwise known as a heart attack, in the U.S. approximately every 40 seconds. You guys, 40 seconds is crazy bananas numbers, okay? So, I mean, within the moment that it took me to begin this and get to this introduction slide, 3 people in the United States have had an AMI. So obviously, heart disease is the leading cause of death in Americans since 1900, and it's only getting worse. So what are we doing to help reduce that cardiovascular death? Well, first off, better public awareness. You guys are going to have all over the place. Hold on just a second, guys. Let me take that off. All over the place, you hear, hey, if it's chest pain, it may not be GERD. Okay, you'll see billboards every now and then. You'll see public awareness on your TV in the form of commercials. You'll hear it on the radio. So public awareness is really big now. Early access to EMS. Ever since the induction of EMS, we've gotten better and better on our early access to help. And when you get earlier access to our help, you get earlier access to definitive help. Okay. So increased number of lay people trained in CPR. And you just about can't go to Kroger or Costco, Sam's Club, Walmart, these big box chain stores without finding an AED or two somewhere in the store. And on top of that, there are different places. In my neck of the woods, AMR and I believe Pafford both have days where they go to a local Walmart or Kroger and they teach people hands-only CPR. It takes people 3 to 4 minutes to learn it completely. And how great is that? It's just something to help others, right? And then, of course, I did say public access to defibrillation devices such as AEDs and recognition of need for advanced life support services. So, hey, I know they're having trouble. I don't really know. Maybe I should call 911 too. Okay, this is an emergency and we're calling 911. We're going to get that advanced ALS. And then your recognition of realizing, hey, this is going to be more than, this is substernal chest pain that I think is cardiac related and not necessarily because this person was moving boxes and they pulled a muscle in their chest. And then, of course, transportation to the hospital. And catheterization and post-arrest care. So let's go over some A&P. All right, first and foremost, we've already gone over the respiratory system. We understand how the diaphragm works, and we also understand how the lungs work. But while we were here in the lungs, we did decide, we looked at this, how on the right side of the body, you have 3 lobes in your lungs, whereas on the left side, where your heart lies in the mediastinum, that you have only 2 lobes. And that's obvious because we want to have room for the heart to just kind of situate itself in there. And as you can see, that's a really good anatomy review right there of where the heart lies. And it's literally just above where the diaphragm is, and it's just kind of nestled in the middle. And it's a beautiful design because if you think about where the where the sternum lies, and how the rib cage all comes together to protect those organs, okay? So the myocardium is also known as the heart muscle. It is a cone-shaped organ, and its main purpose, main function is just to pump blood throughout the body. And you have a pericardial sac, and it's thick, fibrous membrane that surrounds the heart. There's nothing more I can say about that until we get down to talking about some different issues that you're going to have. Visceral layer, that lies against the heart. That's also called the epicardium. So above the cardium itself, or the cardiac, the heart. And then you have pericardial fluid, and that reduces friction within the pericardial sac. So when the heart is beating, and by the way, when a heart beats, if you guys can see me on on video, the heart doesn't beat like this, okay? That's a everybody thinks that. It literally squeezes. And I mean, even though obviously I'm not able to show you all 4 chambers squeezing at one time, but you got to think about how it actually squeezes from the bottom and goes up, because the left ventricular or the left ventricle is the one that pumps all the blood to the body, correct? I know I'm right. So it squeezes that blood in a pumping motion. Well, in between there, you have to have a very small amount of pericardial fluid in between the pericardial sac and that visceral layer, because if you don't, then obviously issues do occur. And by the way, that part can get infected. Then you have your endocardium, and that's the inner lining of the chambers of the heart, and then the surface of the valves. And each atrium receives blood that is returned to the heart from other parts of the body. And then each ventricle pumps blood out of the heart. So let's go to AV valves. You have your atrioventricular valves, or AV valves, and then you have your semilunar and semilunar valves. So you have the tricuspid valve and then the mitral valve, and that goes in order. And then your aortic valve and your pulmonic valve, and those also go in order of the flow of blood. And then you have these papillary muscles, and until we get to the next slide, it's not really going to show you exactly what those are, but the papillary muscles essentially they're kind of like a diaphragm almost, if you will, so that when it contracts, it tightens, and it tightens the chordae tendineae. And so I know this is not like the best thing in the world. Everybody's kind of like, oh no, we're doing A&P, but I promise you, let's get through this part. It's going to be fine. Wow, that's super blurry, or maybe I just have bad glasses on. Okay, so if you guys can look down towards the bottom right, there is the papillary muscles that I was referring to earlier. And you can see the chordae tendineae that it's pulling on, and it's causing a contraction. So, and then you can look on the rest of that and see some of the other things, like where the mitral valve lies versus the pulmonary, the pulmonic valve, tricuspid valve, and others. So let's talk about our coronary circulation. Now, I don't know why. But it wasn't until I got to paramedic school that I realized that the heart also has to have blood flow to it to function. See, I always assumed that, oh, well, there's blood going into it and out of it, so it's fine. But that's not true. So on the outside of your heart, you have coronary arteries. And what they do is exactly what arteries do for the rest of the body. It supplies oxygen to the heart itself. So when one of these guys gets blocked, it's bad. It's real bad. And we're going to talk about the LAD, also known as the widowmaker. And why is it called the widowmaker? Guys, men, that's why it's called the widowmaker, because it makes women widows. They'll have a 99% blockage and have zero clue. There's no chest pain involved. There's no nothing. It's literal sudden cardiac arrest. And pretty much the only thing that they can see is they go back in time and they're like, well, he was more tired in the past few months, and he liked to sleep a little bit more, or every now and then he was just kind of out of breath, and he always complained that hey, he just couldn't do what he normally did. And so when you have a person that's in a certain age group, you may want to look into that and say, hey, maybe you need to go get a heart health screening, just to make sure, right? Because it's okay to be sure. So that's one thing that I always talk about. So the left anterior descending, or the LAD artery, is the one that I was talking about. Why is that so important? So the left side of the heart, that is the ventricle, the left ventricle, is responsible for what? That's responsible for making sure that your heart pumps blood to the entire body. Remember this. Your left ventricle is the most, well, I don't say the most important, but it is definitely, well, yeah, it is. Most important chamber of the heart is your left ventricle. The left anterior, on the front, descending, going down artery supplies blood to, you know what? Why don't y'all tell me? What do you think it supplies blood to? Go ahead, I'll wait. Thank you, Jeremy. Be careful. I get paid to be here until 10, so somebody tell me what you think that artery goes to. Oh my gosh, Jared, you're so great. Lewis, not that lower half of the body, the lower half of the heart, because this is where we're at the coronary artery. So this is going to be the left ventricle. And so let me see if there's a diagram on the next one. There is. And I'm going to go back and forth and back and forth. So good job, guys. Good job. So if you look on the second one, the second picture, it's blurry for me, and I really think it's just my glasses, so sorry about that. But if you look, you can see the left ventricle right there, and it's probably on the anterior view also. Yeah, it's got to be. So let's look at the anterior view. And you guys can see that artery going down. That is taking care of all that blood flow to the left ventricle. Hence why it's called the widowmaker, because guess what happens when we don't have blood flow to an organ? That means we don't have oxygenation. And that means what? That means it doesn't work. So if we don't have oxygenation, we don't have blood flow to it, it's just going to stop working. What happens when it stops working? The left ventricle stops pumping. Is this a big deal? Absolutely. This is why it's such a huge deal for you to understand that the heart itself has its own blood supply on the outside, on the pericardium, okay? And yes, it can cause necrosis. I mean, it's bad. You can't go back from that. There's also the circumflex artery, and you guys can see that one on here as well, and that literally goes around it, the circumference, if you will. Pardon me. Goodness. And the circumflex artery also goes to the left ventricle. I do want y'all to understand that as well. So the supply is even to the interventricular septum and the AV node. Now, EMTs, you may not know what the AV node is. Don't worry, you're going to learn. Regardless if you get tested on it or not, you're going to learn tonight. So I'm not going to say absolutely know this, but you need to understand, okay? And those of you going into paramedic school, the quicker that you understand that, especially about the heart, the better off you'll be. This is building blocks, right? So we can't learn how to spell without understanding our ABCs. So we have to understand our anatomy and physiology, and then we go on to pathophysiology. Okay, so blood vessels. The arteries transport blood through the body, right? And it's not just blood. The blood contains oxygen. And that's our biggest thing. It contains that big nutrient, right? So it's transported all over the body. The aorta is the largest artery in your body. Little side note, one of the coolest things I ever did, and I hope this doesn't come across as strange, but we had a cadaver lab when I was in paramedic school, and so we were able to go in and dissect a person and really get to understand how the body works, the mechanics of whole 9 yards. And so when I found the aorta, when we got to that portion of the aorta, and we watched how the aorta, it's this it's like a U, upside down U shape, comes out of the heart and it goes down. It goes behind the heart and it follows all the way down through the abdominal area, and then it bifurcates, or it becomes two, into the femoral arteries at your hips. Okay, so when we talk about someone later on in trauma, I just want you to put this feather in your cap. When we talk about trauma and somebody's broken their femur, we worry about bleeding internally. So I want you to keep in mind that the aorta is huge, okay? It's coming off of the heart. And if you take your fist and you close your fist, that's as big as your heart is. So let's go back to this slide right here. If this is as big as your fist is, your heart is as big as your fist, think about how large that aorta is. And then that just travels down behind your heart all the way down to your stomach. So I want to impress upon you some of these things, okay? So it does branch into arterioles and then capillaries, and eventually does enlarge to form venules. And then when we go into venules, we go into veins. The superior vena cava and the inferior vena cava do return deoxygenated blood from the body to the right atrium. So these are just things that you're gonna have to know. These are things you're gonna have to memorize. It does not matter if you're an EMT, does not matter if you're advanced or paramedic. You will hear this lecture multiple times. You will be tested on this from this point forward. I guarantee there's going to be a test question on the blood flow of through the heart, and you may see this on National Registry multiple times depending on how far up you go. Okay, so then your blood from the four pulmonary veins will enter the atrium. So I want to also impress on you guys one big thing. The definition of an artery versus the definition of a vein, and this is going to help you in just a minute. If you get these down right now, this is going to help. Are you guys ready? Take notes. Write this down. A vein takes blood to the heart, whereas an artery pushes blood away from the heart, sends blood away from the heart, whatever verbiage you want to use there. But always understand that the vein let me show you what I'm talking about and why that's so important. Everybody's always assuming that a vein is oxygen poor blood.
I tried to remember it as an aorta is a way.
I like that. That's a good KISS method. Keep it simply sweet. I like that. Very good. An artery is a way. That would be good. That's great, as a matter of fact. Wow. Learn something new every day. I don't know who that was that unmuted, but thank you. And then a vein is going to bring it to the heart. Okay. So let's talk about the blood flow through the heart. We are just going to follow the, obviously, through the body. Everything comes into the pulmonary and the veins. So we're bringing blood back in, right? That's going to be our oxygen poor blood. But the oxygen rich blood from pulmonary veins throughout the left side of the heart and into the aorta. I don't like how that's written. Hold on. I think I had a problem last time. Hold on. I'm going to go through these super quick because I want to see if it's in here, and it's not. I don't think it is. Here, it's all the way over here. So put a cap in it for just a second. Let's go back and let's finish this up, because I don't like the way it's written. You guys can look and see the blood flow through the heart on this particular slide, and I know it's in your book, and absolutely run through that, know it, okay? But we're going to go over it in just a second. So what does the blood consist of real quick? Okay, we have plasma, plasma red blood cells, and then we have white blood cells, and then we have platelets. Platelets are super important. We'll talk about more about platelets when we get into neuro and even trauma, but they are big on blood clotting, okay? White blood cells, huge. If we don't have white blood cells, we can't fight off infection. That's why people that are that have cancer and they're undergoing treatment, they can't fight off a common cold. It is opposite. That's correct, Jared. And that's why I'm like, I want to get into it, but it's not there. I didn't like how this was set up last year and I never went back to correct it. So that's my bad. But our red blood cells is the most out of all the components of the blood. They make up the most of the blood itself. Why? Because it carries oxygen, and that's what carries oxygen to the tissues. So the red blood cells actually contain something called hemoglobin, and that's where the oxygen binds, and then it carries. It's like, hey, here's some oxygen. Here's my hemoglobin. Hey, how are you? Oh, I'm great. Let's go to the kid bees. Y'all don't delete me. I have fun with my life, okay? So white blood cells are called leukocytes. They fight off infection, okay? That's all we need. If you want to look at it as like the white knight on a horse coming to save the day, and keep it simply sweet that way, I don't care, whatever makes you happy. And then, like I said about platelets, it's literally just great for the clotting factor, and you have to have them for that, okay? So let's talk about our electrical conduction system. Advanced, go ahead and start listening up and start taking some notes, guys. EMTs, definitely listen up because you need to know this too, okay? So the heart pumps in response to electrical stimulus initiated by a conduction system. And this conduction system begins at the top part of the atrium. And that's going to be called the SA node, or sinoatrial node. And it's the normal site of origin for an electrical impulse. And I say normal because, like I told you guys before, this is medicine. Not everything is 100%, right? So the intrinsic rate is 60 to 100 beats per minute. That sounds familiar. Isn't that the normal heart rate of an adult? Why, yes, it is, Miss Patricia. Wonder why. So when we have somebody that has 60 to 100 beats per minute, and that means that their SA node, the electrical impulse in their heart, working just fine. I'm not worried about this guy. Maybe not as much, okay? So this is a good thing. And this impulse, when it goes off in this SA node, it's going to spread throughout the heart, kind of like a lightning bolt, if you will, except for it's the same conduction area each time, okay? But it spreads through the rest of the heart, and it causes contraction and systole. So systole is at rest, just so you're aware. And this is that conduction system, and you can see the SA node in the top left. And then if you move along the pathways, you'll see the AV node is the next one, and then it flows right on down to Purkinje fibers. It's a whole thing. So look in your book. I think probably we'll go on break and I won't go into all of that. That'll be Chris. So I'm going to let him have all the fun with this. One thing we need to understand, once again, I'm big on patho. I'm big on understanding how things work, because if I know how it works, then I know how to fix it, right? It's kind of like if I know how an engine works, I know how to fix it. So if I know how a heart works, theoretically, I think I got this. Now, can I go out and like dig in someone's chest and fix it like with tools? No, I can't. But if I can visualize it, I know what the next steps are. So we need to understand that you have these electrical properties inside each cardiac cell. Now, when you guys go way, way, way back to when you were in high school and you learned about A&P, you learned that cardiac cells were only found in the heart muscle. Why? Because we don't want our toes getting shocked, right? Right. That's why they're only found there, because they are so conducive to the electrical properties of our electrical system. So there's an excitability, and that's the ability of the cells to respond to any electrical impulse. Good. So if I have my SA firing off, I know that the rest of my heart's going to do what it's supposed to. Conductivity is the ability of the cells to conduct the electrical impulse. Remember, if they weren't this, the cardiac cell itself, they wouldn't have the conductivity to do so. And then you have automaticity, and that's just the ability of the cells to contract without a stimulus from a nerve source. So they have the ability. Okay. So let's go through a physiology review. Now, you have regulation of heart function. And let's go into the EMTs. I kind of talked to you guys about chemoreceptors in the heart. And they're not just in the heart, they're also in a couple other places, but baroreceptors as well. And so we're going to talk about those here. Your autonomic nervous system, your automatic one, the one where you don't know that, hey, you just got through eating lunch, or maybe you're munching on something right now. Can you feel your intestines? Can you feel your stomach doing the thing it needs to do? No, you can't. Why? Because the autonomic nervous system is regulating all of that. So what it does is this controls the heart's chronotropic, dromotropic, and inotropic state. Ionotropic. I don't know why I said that. Ionotropic state. And so these three states are what makes sure that your heart has rate, quality, and timing. Okay, so the receptors in the blood, they literally constantly are monitoring stuff. And we talked about homeostasis a little bit in the respiratory system, and how if you have too much carbon dioxide, what happens, or if you have too much oxygen in your system, how you hyperventilate or hypoventilate, depending. Well, your heart is the same thing. There has to be a maintain of balance. So you have baroreceptors, which if you've ever heard of something called a bariatric patient, that means that's a heavier set patient over the normal range. And so baro meaning weight. So write that down somewhere if you don't know that. I love the keep it simply sweet method. So I like to put things together. Bariatric patient, weight, baroreceptor, pressure. So do you think that if somebody was a bariatric patient and they stepped on your hand, would it hurt? Is that pressure? Not necessarily hurt, but is there pressure there? Absolutely. So it's the same thing for me. So it's within the heart and even some of the main arteries. As a matter of fact, the main one where the baroreceptor and chemoreceptors are is directly above where the atria, the left ventricle pumps blood into the aorta. So as the left ventricle does the squeezing motion and it comes up and it goes into the aortic arch, right there are two different receptors. One is a baroreceptor, and it's checking out the pressure. And then there's a chemoreceptor, and it's checking the chemical composition of the blood. So if I don't have enough oxygen, we're going to pump a little bit harder, right? If my pressure is too low, we're going to try to pump a little bit harder, right? And that's when you have that autonomic nervous system is going to have a backfeed of chronotropic, dromotropic, and inotropic state. All right, so cardiac cycle. Now, hold on just a second. Okay. So during the cardiac cycle, you have, it's essentially just the pumping of the heart, right? The cycle is going to begin when the myocardial contraction and it concludes at the beginning of the next contraction. So it's one full beat, okay, from beginning to end. And we've already talked about how, I'm sorry, I misspoke earlier, and I knew it was wrong when it came out. I was like, systole is not the resting of the heart rate. Chris, you could have called me on it. It's fine. Systole, so you have your systolic blood pressure, which is the highest pressure in the body, or you have your diastolic pressure, which is the lowest pressure that is contained within the cardiac system, the veins, the arteries, all of it at one given time. So systole is the contraction, and then the diastole is the relaxation of the heart. So I apologize for misspeaking. So you need to go back to your book and be like, okay, she's crazy pants tonight. Apparently I am. My apologies. So let's get this one straight. Systolic pressure is up here when we're writing our blood pressure. Diastolic is down here, right? So systole is the contraction, and then diastole is the relaxation. Okay, now let's get into some fun. And y'all are having fun, right? Someone put yes in the comments for me. So I need to know you guys are having fun. I'm having a great time, not gonna lie. Preload. Okay, thank you, Michael. Preload, okay? You guys, you need to understand what preload and afterload is. Before we move to the next slide, oh, I love it. Time of your lives. Yes, thank you. Okay. Sure, thank you so much. Don't sound so convincing. But seriously though, guys, before we leave this slide, you need to understand these two things. They're very simple. It's not hard to get. Preload is the amount of blood returned to the heart to be pumped out and directly affects afterload. So preload is just the stuff that's coming in, okay? Afterload is the pressure against which the left ventricle must pump blood. So afterload is going to be pressure in like the aorta, and it's like a peripheral vascular resistance, if you will, against which the left ventricle has to pump that blood for it to get out. So that's very important for y'all to understand. And I know essentially I'm just reading the slide, but if you understand what peripheral vascular resistance does, if you think about it, it has to get to that point. If it does not get to that point, if afterload is not met, then you don't get perfusion at your end organs. Why? Because your blood is not being pumped appropriately. Okay, so since we're going to go ahead and start talking about it, let's talk about something in here. EMTs, I want y'all to understand this. Cardiac output equals stroke volume times heart rate. And you're like, hold on, what did you just say? This is easy. Y'all know what a heart rate is. You know, you're just like, okay, we're going to count for 30, 60 seconds, right? Okay, that's our heart rate. Awesome. So we're just going to say 72 because I'm pretty excited. And we're going to figure out stroke volume. So can we do that in the field? Yes and no. But you take their stroke volume, which is 1 beat, and you multiply it times heart rate, and that is your cardiac output. That's what this body is getting. In 1 full minute, that's what's happening. So if you have poor cardiac output, you're going to hear this again. If you have poor cardiac output, you are going to have a perfusion problem, and later on. You're going to have a oxygenation problem later on because the organs, not the heart, are not getting an adequate enough blood pumped, and blood carries hemoglobin, which carries oxygen, okay? So I like for you guys to understand that patho before we move on. So what are some of the factors that can influence heart rate, stroke volume? Anything that does that, it's going to affect your cardiac output and then the perfusion afterwards. So let's talk about how you can take some medications that will make your heart rate go through the roof. You can think of any illicit drug that's out there that my apologies. Any illicit drug that's out there, let's say an upper. Crystal methamphetamines is one. Take a normal heart, and that heart rate can be 120 plus. Now, is that patient having enough time for the heart to fill up with blood appropriately to pump to the rest of the body? Nope, they are not. There's another illicit drug you can take that will lower your heart rate. Also, same thing. The blood is just kind of sitting there. I mean, yeah, it's there, but it's really not doing the effective stroke volume, if you will, okay? Now, Starling law of the heart is huge. So what does this mean? It increased venous return to the heart, stretches the ventricle to some extent. This results in increased cardiac contractility. So if we have an excess amount of venous return blood to the heart, it's got to go somewhere, right? So as it's sitting in the heart, as it's going through and it's pumping, it's doing its thing, it gets to the left ventricle. Well, the left ventricle is the one that's the truest of the cardiac muscle because it pumps, right? It's the one that's responsible for pumping to the rest of the body. So because of the fact that now there's more volume, now I got to get stronger. I got to get a little bit bigger, and it's going to stretch a little bit more each time. And then let's not forget about ejection fraction. That is the amount of blood returning to the right atrium, and that may vary from minute to minute. Okay, and I'm going to go ahead and tell you, not every single person walking around right now does not have a perfect heart rate of doom, 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 doom. There's always someone, like when you take a breath, you guys can do this at home. Do this to any of your family members. Just hold on to their pulse on their radius, okay? And have them have a conversation with you and feel that heart rate. When they take a breath or when they exhale, that heart rate's going to change just a little bit. And that's because of the ejection, and the ejection fraction is also going to change. It varies from minute to minute, but the normal heart continues to pump out the same percentage of blood, even if that heart rate does vary a little bit. There's like some wiggle room because we're going on percentage here. Okay. So blood flow within the heart, you have, then this is the one I was talking about. I can't remember who said it. Let me go back up here and find it. Jared. Jared's the one that pegged this one. Okay, so in the lungs, blood is oxygenated, right? Carbon dioxide is off-gassed, other waste products are removed, right? But we're getting oxygenation. That's our main thing here. Freshly oxygenated blood is returned to the left atrium through the pulmonary vein, because we're bringing blood back to the heart. It's just called the pulmonary vein because it's bringing blood back to the heart. That's why it's called the vein. It's, if you put pulmonary in front of it, it changes the fact of deoxygenated to oxygenated, but it's a vein nonetheless. And as long as you understand that veins bring blood back to the heart, slap the word pulmonary in front of it and you're Gucci, guys. You're great. You've gravy. You got it. And the same thing is for the opposite. So after oxygenated blood has been delivered by the capillaries, deoxygenated blood is returned to the heart. So, and I just want to make sure I got everything over here on this one. Yeah, I did. Okay. Pulmonary circulation. At this point, their pulmonary circulation is also getting reinvigorated with oxygenation, right? And it carries blood from the right side of the heart to the lungs and back to the left side of the heart. And then you have your systemic circulation is responsible for all blood flow to the rest of the body. Why is systemic? It's the system. It's the whole thing, okay? And then you have systemic arterial circulation. Now, this is where you have oxygenated blood is going to leave the heart through the aortic valve and passes into the aorta. And from the aorta, blood's just distributed to every part of the body. Okay, so y'all ready to get into some real stuff? All right, pathophysiology of chest pain or discomfort related to the heart usually stems from cardiac cell ischemia. Remember what I said about, hey, if you're munching on something or you've already eaten something, you don't really feel that your stomach's doing anything. Well, do you feel your heart beating right now? You know what? Let me rephrase that, because some people can't. Can you actually feel your heart doing much of anything ever? No. It's just kind of there. It's dormant. It does its thing. Okay. But let's have some ischemia and we're going to know about it. Okay. We're going to have a problem here because the cardiac cells, as they are dying, there's decreased blood flow to whatever that area is. It's going to send off a lot of pain receptors, and it's going to be different for different people. Like males mostly have chest pain, whereas women, we're just made different, and that's okay too. There was a woman that I got, and this is a whole side note. I had never heard, or I had heard this throughout my entire life of going through school about how a woman can have jaw pain, and that means she's having a heart attack. This woman presented with absolutely normal skin. She appeared normal, was walking, talking, and said, my jaw just won't stop hurting and I'm so tired lately and I just don't know what it is. And I know I need to go see a dentist, but they made me call you and I don't know why. And I said, ma'am, would you mind sitting down for me? We're going to do a 12 lead. She was having an MI. She was actually having a STEMI and I flew her out she was over an hour away from definitive care. So I flew her out. That was no problem. Saved her life because she had jaw pain. So women are a little different than men. They can have back of the neck pain, jaw pain, and stuff like that. Whereas men, normally you're going to see the pain or the radiating pain in their left arm, hand, even numbness and tingling, stuff like that. Okay, so heart tissue that fails to get enough oxygen and nutrients, it's gonna say, hey, we have some problems, we need some help. So that's going to be your first indication that something is wrong. So they say you know your body better than anyone else. Your patient knows their body better than you. So when you go on these scenes and you're talking to these people, and anybody else that may have not paid attention as much in class may have just told this lady, yeah, you probably have a toothache, go see your doctor. But I didn't. I listened to her because I knew that this was a possibility. I've only run one, and she was the only one in my entire career. Am I glad I listened to this? Absolutely. I hope you listen as well. So when you go to a doctor, you tell them what your issues are, and you hope that they listen. I want you guys to do the same for your people, because it's so very important for us to turn around and be as empathetic and a listening ear for our patients, okay? So let's talk about atherosclerosis. Isn't that such a beautiful word? Do not ask me to spell that. Back pain is common for women having an MI and STEMI. Yeah, that's another one. I wasn't going to go into all of them, but Lindsay's 100% correct, and I thank you for putting that in there. And they will even have lower back pain. That's what's crazy. A lot of, from what I've heard, I've not actually had a woman picked up for lower back pain ever. But yeah, they're like, no, I just have a kidney infection. No, you don't. You're having some issues. So what is atherosclerosis? We're going to talk about it, but it literally diminishes the blood flow to the myocardium. How does it do it? So how many of y'all, and I'm really going to sit here and wait because I need to take a drink, put me in the comments if you eat at McDonald's or if you have eaten at McDonald's in the past year. Go ahead. Or Wendy's, Burger King. Go ahead. Oh, wow. I love you guys. Thank you. That was a whole bunch of me's at one time. Me too. Their nuggets are on point all the time. That ice cream machine may not be working, but those nuggets are. Okay, so what does this do for us? Well, the cholesterol and that fatty substance that comes from all of that nasty, it causes something called plaque, and that builds up in our blood vessels. It's high cholesterol. Do you know that even if you have the healthiest diet in the world, you can still have atherosclerosis simply because it's a genetic disorder? So I don't cheddar bacon. I have to stop reading that, Lindsay. I have not had dinner, but I may have to go to Wendy's after this. So thank you. I don't know if I should thank you or if I should feel like that's evil, but thank you. So this cholesterol and fatty substance, it causes this plaque, and there's this really good, I'm sure it's in here. You're welcome. I love this class. But there's this really good picture right here. I'm going to go ahead and show you. And as you can see, the plaque, the fatty tissue is going to be kind of in that yellow color. That's your plaque, right? And what happens is it just builds up over time, and it builds up over time, and it builds up over time, and it builds up over time until you have I don't know, 100% blockage of the LAD. And then you fall down and you don't know why. And it's because of all the McDonald's that we ate. Okay. So not to do that whole what? Oh, Jared. Look, with a comment like that, I'm taking a screenshot. Okay. I apologize for anyone who is not watching this and they're just watching the replay, because I don't know if you could go through it and find that or not. Jared is also now my favorite. Lindsay, he outdid you. 100%. Okay, I gotta pull myself back in here. Is that what that is? Oh, Tammy, stop. It is not on the menu, okay? Forget Wendy's. Okay, we totally did a dumpster dive into McDonald's. Let's reel this back in, y'all. Okay. So atherosclerosis can cause that complete occlusion, like I said, and it can extensively damage the coronary arteries to the point where, like I said, you can have that 100% blockage of the LAD, or the left anterior descending. I'm going to get a text over here from Chris in just a second. I promise you. He's going to be like, all right, come on now. Let's go. Okay, so let's talk about oh, my phone went off again. I thought it really was him. Okay, so let's talk about a thromboembolism. Now, you have a blood clot and it gets stuck. You have this nice little clot. It's flowing along. It's floating down the river of blood vessels, and it says, oh, I got to a place where I can't get through. Now we have an AMI, okay? Keep going, no one's fussing. Chris, Walley, thank you. Okay, so as you find that, this is where we're going to have, and you can see right here where the infarct is. You can see where the clot is on this nice picture, and then you can see the damaged heart muscle. So we have an infarct where there's a problem, okay? You are not. Oh, I thought that was Chris. That's Jared. Jared, go ahead. I can't tell you can't go somewhere and get something, but Chris has to stay here because he has to teach in just a second. I'm going to go get some when it's his turn, which is in 8 minutes. You're welcome. I don't know how I'm going to stay on while I'm driving down the road, but we're going to figure this out. Okay. So does this, but I know we're kind of getting off subject a little bit here, but hey, does this make sense that, like, when we don't have blood flow to somewhere, it hurts, right? We're going to feel that pain in our chest, or we're going to feel a pain somewhere. And I really do hope that that does make more sense. Hold on. I feel like I missed something here. Let me go back over this one more time. A thromboembolism is going to get stuck. Okay. And when it gets stuck, it's going to cause an infarct. In this particular case, it's an acute myocardial infarction. Y'all got my head somewhere else. So that's going to block that coronary artery. And let's just say that is the LAD, the left anterior descending. That's bad. That's real bad. So what are some of the major controllable factors? Okay. Not eating a McGangbang is one of them. Jared. Okay. And Lindsay and Tammy and anyone else on this chat over here. Okay. I know, I'm so sorry. Every now and then it's okay, but not daily. Also, cigarette smoking. It slows everything down and it causes so many issues. And vaping is the same way. What's another controllable factor? High blood pressure. We can take medication for that. Elevated cholesterol levels. We can take medication for that too. And change our diet, of course. And high blood pressure, there's another one. Decrease your salt intake. I know that sounds really crazy. There's a whole patho behind it. Not going to get into it, but salt is bad for the body in excess amounts, which, by the way, you find in definitely a McGangbang. And also anything else over there in that chat. I didn't hear any one of y'all say anything about Brussels sprouts, which are only really, really good when sauteed in a lot of butter. So that totally defeats the purpose here. Salt is fantastic for hangover prevention, though. That is actually correct. Thank you for putting that in there. Salt, but that's because you've depleted the salt in your body after you have drank enough to cause a hangover. So, those are all out. And bacon. Jared. Let's see. Y'all are killing me. Okay. Elevated blood glucose levels. So it's not just diabetics. I do want you to understand this, but over time, if you have an elevated blood glucose level, your pancreas is not going to work right. And because of it not working correctly, you're going to start building up atherosclerosis in your veins. So neither one are good. All right. Lack of exercise. Welcome to the cardio chapter at ARES, girl. Yes. That was so not professional. Can we delete that part? Stress. Yo, I drink pickle juice. I'm not reading that out loud, Joshua. Okay. Also, pickles are nasty. Go ahead and judge. It's fine. Stress. Guys, I cannot stress enough that you should do things to de-stress your body. You talk about lack of exercise is one of the things that we can fix. Okay, well, there are people that have so much stress in their lives, they don't know how to relax at any point in time, at any given moment, and you have to find that. And in some cases, you can find that through exercise, not necessarily diet. Now, diet is really good, don't get me wrong, but one of the biggest things that, and it's kind of a buzzword and a buzzkill, if you will, when you say, oh, I'm going on a diet. I don't do diets. Okay, I am a big girl from Mississippi. We deep fry butter here. Okay, that's where it came from. All right. I like the taste of food. I love all things under the sun to eat. But here's the deal. I should be like 1,000 pounds, but it's called moderation. It's called walking. You get out and you walk 3-4 times a week to defend that. You go and you get your heart healthy checkups. You find ways to de-stress your body, because stress doesn't just kill the mind, it kills your heart. And when it causes, and it can cause, a buildup of atherosclerosis because of the fact that your body is just shutting down. So we don't want those things, okay? Stop it, Tammy. Lindsay, you're my favorite again. Thanks. Now I want a deep fried Oreo. Sorry. Deep fried Twinkie. I've never had a deep fried Twinkie. We're going to have to go on break. I'm going to have to go get food. Which it's 6:57 anyway. Chris, I hope you're ready. I hope you're on your AB fried game tonight. Rob, I can't with these guys. They're bad. Okay, y'all. I am you're awesome, Chris. Okay, guys, I am gonna go ahead and stop sharing, and I'm gonna go on break for about 10 minutes, and Wally will be back. Chris will be back. He is going to teach the remainder of this chapter. Thank y'all so much for coming. I'm not leaving. I'm really not going anywhere until after class is over to McDonald's and Wendy's. So thank you for that. But I'll be in the chat if y'all need something. Okay. And I'll be checking my emails too. So 10 minutes, guys. Thank you, guys. Thank you, Jared.
Hey, just want to let y'all know before y'all take a break. I won't be turning my camera on. I kind of had a small procedure today on my eye. So I don't think you want to look at my ugly self. So let's say 7:10, we'll meet back and I'll start talking at 10 after 7. See y'all in a little bit. All right, so now let's talk about angina. So what is angina? I know Patricia was going over some, tried true things. I want to share something also. Have y'all ever heard of like the cardiac sweats? You hear people having when you walk in the door, you're like, oh, this dude's serious. I can tell he's having the cardiac sweats. And you're like, what's he talking about? Has anybody ever come across those? I'm gonna pull up Patricia. I'm here till 10. Okay, so all right. So for the ones that have not, I'm showing my age since Lindsay's saying not in her 10 years. Well, guess what? I have. So the cardiac sweat. So when we talk about that, it's not like, oh, I'm gonna joke around and say it's not like the meat sweats where you eat so much and you're just like, oh, I feel like crap. It is more of a sweat that is all over your forehead. It looks like a bunch of, and I'm not trying to say like a million little BBs, but you'll have a couple less than 100 sweat beads that just form up on somebody's forehead. Well, the difference between a cardiac sweats and you're just sweating because it's hot, like it is in the South, is the cardiac sweats don't run. They don't run down the face. You can wipe them off, clear their face up, and then within a few minutes they'll come back. So those are some of the little telltale signs. You can walk in the door and be like, is he sweating? Like, I mean, I know I'm a big boy, but that's it's a different. So like their whole body will be cooled and kind of a moist, kind of like when you go to touch them, they're just like, oh, he's clammy. That's not nice. So that's what a cardiac sweat is versus the other ones. So when you talk about those, you looking at your somebody, you're kind of getting your preview of your patient status from the door. So as we go through here, I wanted to add that in there. All right. So angina pectoris. So basically what it is going through is that certain periods of time, the heart tissues that we all love and thank God they do their own function on their own, they're just not getting enough oxygen to function. So you hear it called more of, oh, I'm having some angina. Well, that's still serious, but like what's going on? Oh, I have it like 3-4 times a week. Okay, bruh, you're not doing good. So in saying something like that, you want to take that as serious, as a very serious. So they will describe that pain as basically having some discomfort. It is not a long gated period where they're not complaining of time and time and time it's hurting, but it is something that it's brief and is very discomforting, but at the same time it is pretty well relieved pretty promptly. What are they saying? So angina is typically described as some crushing, squeezing, or like somebody standing on my chest. Well, I'm just gonna straight up say, if you standing on my chest, we I hope I'm not breathing if you're having to do something like that. So most of the time when these patients are feeling some type of angina or anything like that, it is going to basically be in the mid chest area. It is going to be right underneath the sternum, and then it's going to start to radiate, but from the jaw down to the arms and their mid back. So those are going to be the areas where you turn in and say, all right, so this is what's going on. You're kind of getting and some understanding that our patients are starting to have some cardiac related issues because those are going to be the same areas, the same complaints, same chief complaints that your patient is going to have during your basically MIs and your normal cardiac events. All right, so a single episode may be a precursor for an MI that is coming on. You can have stable angina, so stable and unstable angina. So stable angina occurs at a relatively fixed frequency. We know it comes on and goes off. You can fix it with some medication. A lot of people will turn around and say, oh, well, I just took some indigestion medicine or I drink some Sprite and I feel better. Okay, well, that is true, but how often are you doing that? 3-4 times a week. Well, there's reasons why that's doing that, but let's go get you seen. So the difference between stable and now we're going to talk about unstable is it does occur without any kind of frequency. It just comes and goes. It may not be relieved by the same old medicine that you've had. Those two things are kind of like, okay, it is a frequently a common thing that's going to be more of your stable. Unstable is when they get it and they can't get it to go away. Then it finally goes away on its own, and then 2-3 hours later it'll come back. It is more of a progressive state. So I'm sorry, I was trying to read a message that just popped up. So progressive angina is stable or unstable angina. That is it's accelerating the frequency and duration. So We know that there's some cardiac issues going on. We understand it. We realize that, but is it more stable? Is it unstable? So we're trying to figure out, basically, it's kind of like, easiest way I can say it, it's kind of like we're trying to take care of an OB patient. How frequent are their contractions? Because now it's through the heart and they're not getting enough oxygen for the angina. So we need to know, is this a common thing that's going on? Or is it just come and goes and it's random? It's kind of scared you. And that's now why we're here, is because it's got something that scared you and you're like, oh, something's up. I don't feel good. So that would be more of the unstable. All right. So an acute MI, or acute myocardial infarction, most deaths from an AMI are ultimately caused by dysrhythmias. So you see that dysrhythmia, that it can sometimes be prevented and or treated. Prime example, a couple weeks ago, I was not able to attend one night. Rob stepped in for me. We ended up having a cardiac arrest on our platform. The gentleman, come to find out after the time and done some investigation, is he had been complaining of this in the morning, kind of saying that his shoulder hurting, having some issues. So those are the things that we know that this person is starting to have this acute MI. Well, he was having the pain because of it's the death of those cells that's within the heart area, and now the blood flow is restricted. So there, we could have seen it. I could have seen some change. I could have done a 4-lead or 12-lead and noticed something that was different. For this particular gentleman, he did not speak English. He spoke very fluent Spanish, but still, if we would have taken this serious and when him come see me, we particularly could have seen it and sent him on into the hospital. Now, granted, do I think that would have saved him? Unfortunately, no. He had a massive heart attack from the time that we started our CPR, and I initially did not. I went from a very sinus rhythm to a sinus Brady to nothing. It was done. Um, Even with drugs, I never had a chance to be able to shock him. He had a massive MI. So, do I believe that he would have died on the table or inside the hospital? Yes, I do. So, those are some of the things that we have to take serious, and that's why we preach about it. If you're having issues, or do some education on the way to your facilities, tell your patients, hey, look, it's okay. I'm fine. I would rather be taking care of you than having to do a transfer. Just let them know that they're not bothering you, and you doing your job is because that is our job for us to be able to do that. So, given a little bit of, I love to say, the backseat education, because that's the time that we get to spend with our patient, to let them know that what they're feeling from either the angina or the AMI, we know that that's common. That's our jobs, is to recognize that and to push forward. All right, so signs and symptoms. We talked about this. Y'all have probably seen these in the past, and you hear people talking about it. So you get that very sudden onset of weakness, nausea, and sweating. Now, again, we talk about the sweating. It could be full body, or it could be those cardiac sweats. So pay attention to that, and still don't brush it off because, oh, he doesn't have the sweats like Walley said. It's not always there, but when you do see that, that will tell you that's an indicative sign of something's going on. They will complain of a lot of pain, discomfort, and those pressures within that lower jaw. I could have sworn years ago I was having a massive heart attack. I ended up going in, and they did all the cath search. Well, they didn't cath me, but they ended up doing all the searching. Come to find out, my gallbladder had stopped. It was in the arm, it was in the jaw. I had all of those things. But the bad part is I knew what I was supposed to be looking for. I was like, oh God, I'm having a heart attack. I'm too young for this. So, hold on, fist and sneeze. Excuse me. So you get that irregular heartbeat, a little bit of syncope that's in there. They'll complain of that shortness of breath or that dyspnea, where they're just not able to do it. They can't tell you what's going on. So that being said, is pay attention to that. Put them on that non-rebreather versus that nasal cannula. You may end up fighting with your patient, not as it's physical, but because they feel like they're not able to breathe through that NOMR breather. But no, with their shortness of breath, just tell them, hey, all I need you to do is nod your head up for yes, shake it side to side for no. Simple, small answers is what they need to give you to your question. So don't ask a very detailed question. We just need something very short, sweet, to the point, and go from there. I know it talks about the pink frothy sputum. That is not uncommon to find. A lot of people will turn around and say, "Oh, they're having a seizure." Okay, well, that's what it looks like, and I can understand that from a layperson. But when we look at them, we see that frothy sputum in the corners of their mouth. That's it's more the signs of an MI that's going on. And obviously you have that sudden death, and it's quick, it's fast, it's this is the point. Here we are, it's done. We're not going back. Yeah, that's right, Lindsay. It is the VTAC seizure because that's something that you see. You recognize that going in, and you're like, okay, they're having an irregular heartbeat. Now, understand when I say irregular heartbeat, it is not going to be marched out every single time to be irregular. It can be irregular, which means it's going to be all the time. You're going to have 2 or 3 look the same, and you'll have 4 or 5 that are going to look the same. So all that is still going to be an irregular heartbeat that is not supposed to be there. So knowing that, when you put them on the monitor, or you look over at the monitor because your partner's put them on there, and you're like, "Hey, bro, he don't look good." Now I have the hiccups. What in the world? So no, when somebody's having an active MI and they're having all these signs and symptoms of what's going on, unfortunately, the sudden death is going to take place fast. It is going to be, this patient is probably going to pass in the back of your ambulance. Or while you're assessing this patient inside their home, because we don't know how long that they've been going on for. All right, some physical findings, what we're going to see. What we're going to just look at them and say, yours says that patient often feels frightened. They're scared poopless. That's the nicest way that I can put it. I can be very blunt, but we're just going to say, I'm going to be polite. So, Rob and Patricia, I know y'all surprised. All right, so they're going to be scared. They're going to have this look of just ultimate fear, like, I'm dying. Ultimately, I hate to say it is, they are. They're there. They are not used to these pulses, the increase of the pulse rate, that shortness of breath, because all we hear on TV, every time we go to the doctor, we see all these posts, we see these posters on the wall, we hear of this jaw pain, left shoulder pain, shortness of breath. It's a massive heart attack, and if you don't be seen, you're going to die. Well, that is the worst case scenario, yes. But I will say a lot of people that I've come across in my time, they have this, but they do wait. They wait it out. Oh, I've had this before. Get a little bit longer. It'll be okay. Yes, you're right. Because after a while, it will all stop, and you will be in the most stable rhythm that there ever is, and that is asystole. So, but that's not what we want. We don't want our patients to, we walk in the door and we're like, yep, he's dead. He's dying. He's having MI. All right, y'all be careful. That's not us. We need to be there for our patients. We need to take care of them. But when the time presents, let's turn around and give them some education. Sometimes patients will also experience some that impending doom. So they are gonna tell you, "Don't let me die." Okay, because I don't. It's hard to tell a patient, "I'm gonna do everything I can. I'm gonna make sure you make it." Well, you can't promise that because we don't know. We don't know those things. We are not, once we lay hands on somebody, we're just not going to save everybody. But a lot of times I'm going to do everything I can, that there's not going to be one thing that I don't do that can help you in the best way I can. I'm giving them the best answer I can, but I know we got to give that bolus of diesel and a lot of sirens and some flashing lights. Get me there now, because this patient does need a higher level of care. And truthfully, somebody that is way smarter in the cardiac system than any of us. I'm not knocking nobody. I'm just saying they know it. They know what's going on. Okay, so consequences of AMI. Just going to say the top one probably says it all. So you all, obviously we know that the result of cardiac arrest is when the heart fails, they start to generate some effective blood flow. The heart does fail to generate effective blood flow. So we know that they're not doing so good. Obviously, we're going to have a cardiogenic shock. You're going to have some heart failure. But there is a lot of other things that turn to be lethal and non-lethal dysrhythmias that may also not be from an AMI. It could be situational. It could be stress. It could be the event that's going on, a very traumatic situation. You will see those different rhythms, but none of that is going to it's not going to put our blinders on. We're going to have that very open view. We're going to try to pay attention. We're going to try to say, we want to figure out what's going on. Some of the other rhythms we may come across is tachycardia. So to be in a tachycardia rate, it has to be greater than 100 beats a minute. Now, bradycardia is anything less than 60. So you talk about a normal sinus. Well, it's anything between 60 and 100. That is what is supposed to be normal. Now, granted, obviously, I went into the doctor today. My pulse was a little high, and the girl's like, "You nervous?" And I was like, "Actually, no, I'm not. It's just I have the white coat syndrome. It doesn't matter what I do. My blood pressure, I try my best. It was elevated, but it's the situation that I was in." Excuse me. Then you have ventricular tachycardia and ventricular fibrillation. So to be classified as a rapid heart rhythm, it needs to be normally between 150 to 200. So that is when you get that uh, the tachycardia, but now you know, holy cow, that's super high. What goes on? So we know it during that time. You have all your nodes that are sending all these electrical currents and they're firing off. It is not. It's not consistent enough to be a viable rhythm. So we have to figure out, okay, what do we do? How do we hit this restart button? Where's the easy button for this patient? And it's not going to be like that. So when you see anything that's higher and then the 150 to 200, most of the time this rhythm does usually not follow some adequate timelines. It does beat for the left ventricle to fill the blood flow. VFib or VF is disorganized, which means it's like me, it's just not really common. It's special. So you have your ventricular fib, and VFib is a very disorganized, it is an ineffective quivering of the ventricles. So what causes that is some unorganized electrical activity. Now, what do we do for them? Well, we can defibrillate them, and sometimes we can give them some certain medicines as a medic. I can turn around and give them some medicine and help restart their heart. The very first time I ever did this in my career, it was the assistant district attorney for the state of Mississippi. Was I scared? I think I was in VFib too, because I think I was quivering. I think I was shaking. I was like, oh God, I'm just gonna kill this man. I don't know what to do. So but when we talk about shocking them, so we can defibrillate them to restart their heart, we're going to send electrical impulses through them. We're going to shock them with a certain electrical current. And what that does is it stops all the electrical activity and in a very big an attempt to restore them to a normal beat. And that's the plan. Sometimes it doesn't always go that way, but that's the plan. Now, worst case scenario is they go into a systole. And then again, that is in the absence of any cardiac electrical activity that's going on. There is no mechanical, there's nothing going on. And to kind of describe it, so if you see in the very top one, that is a sinus tachycardia rate because it is very fast. You notice your R waves. So your R waves are right up here. So this is an R wave. So we have our P right here. You have your Q right there. Your, and then S is down here. And this is a T wave. So when I talk about it, I was going to let you know. So you'll see how fast that they are and how close that they are. You have to look at them and turn around and look at their rate so we can figure it out. That we know that these things are their rate and rhythm is high. And B, we'll notice how it's spaced out. And I'm going to get something to drink. So we notice it's spaced out. We notice there's some between your T wave and your P wave, there's some flatness there. So it's slowed down. So you notice it's a bradycardia rhythm because it's less than 60 beats a minute. Then you go into sinus brady. That's not good either. We don't like that. C is a ventricular tachycardia. That's what I was looking at. Didn't read the number. So ventricular tachycardia is everything's going nuts. So you're like, oh God. So the best thing we can do there versus A is we know our rate and we know our rhythm. If we're looking at C, everything's through the roof. Most of the time, you're going to be anywhere between that 150 to 200. So, and then D is a ventricular fib. You know, it looks like my little girl is trying to color. That's what, and just to be honest, she's just all over the page. So it's everything's firing and it's just doing what it wants to do. And then you have E, and E is, like I said, that's the most stable rhythm around, but your patient won't talk to you, just FYI. So they're not even breathing for themselves. That's when you're like, oh crap. Okay, guys, we gotta start some CPR. We gotta do something. And then everybody's looking at you like, well, what are we doing? So that being said, is we just need to make sure we're on the same page, we're moving right. That is, I don't expect everybody to memorize what those are. It's nice to know. My advances, I would like for you to start looking at those rates and those rhythms and picking up what they are. Basics, it's just bringing you into it. It's kind of showing you the different what they squiggly lines look like. That kind of build some of that muscle memory. What you're looking at, what you're seeing when you look at the monitor. Biggest thing is looking at your rhythm and then your rate, knowing what the rates are and what beats per minute you're supposed to be looking at. That will help you understand. Okay, well, like, and then ask your partner when it's over. Hey, what rhythm was this guy in? What rate was this lady at? So does that make her a Brady, or does that make her a sinus rhythm? I'm just trying to, and they'll be able to help you out. And the stuff that you see is going to help you and grow and learn more and more. All right, so cardiogenic shock. Now, we know this is often caused by your myocardial infarction. And the reason why is because that heart is lacking enough power to force the blood volume through the circulatory system. Now, there may be some oh, why am I having trouble tonight? I'll let y'all read that one. From some hypovolemic shock, we know that their chief complaint at this time is going to be chest pains. You'll have that dyspnea where they're having trouble getting those words out. We talk about our tachycardia. Their rate is going to be elevated. We know that when we start talking to them, it's because they're nervous. They don't know what's going on. Now, if we look at their heart rate, you may see some bradycardia there. You may see that excessive tachycardia. You know, you'll have from peripheral edema, so you'll start to see that swelling because they can't get rid of the fluid. It's there. We're going to see the dysrhythmias that are coming across the monitor. You'll see that JVD, or the jugular venous stitching in their neck. You're going to see that was bulging out. So what that's telling you is that the blood flow is having trouble being pumped because it's going to look like a big old rope in their neck. It's huge. If you listen to them and you're auscultating those breath sounds, what you're expecting to hear are some rails. You'll start to hear those crackles. It'll sound like Rice Krispies, like that snap, crackle, pop. You'll hear that. That's what we want to look for. I've said this time and time again. Always, always listen to your patients. no matter if they're complaining of shortness of breath or they are, listen to those patients and let them just listen to you. So that way you're building up that memory of what lung sounds sound like. There are some really good YouTube pages out there that teach you what different breath sounds sound like. But I'm telling you, put your stethoscope on your patients. That is the best way for you to understand what is going on, because now you get to talk to your patient. You get to hear exactly what they're saying, what's going on with them, what they sound like with these particular signs and symptoms. Again, so we're going to have our initial evaluation. Our treatment plan is going to be the same. You'll have that signs and symptoms. So the reason why they're anxiety or they're restless is because they just don't feel good. They have this, I don't know what's going on. I'm nervous. I can't sit still. I can't catch my breath. They're going to try to be leaning over. They're going to sit up. They're going to lean back. They're trying to make their chest bigger than what they seem, but gravity pulling if they lean forward, gravity is going to be pulling with them, and it's going to be able to try to help open their chest cavities. So they want to get more air in because they're, as it says right there, they're hungry for air. They need as much air as they can because they're short of breath. We know it can also be characterized by a very rapid and shallow breathing. They may have some nausea and vomiting, and a decrease in some body temperature. So you'll probably see them shivering. They will potentially be sweating at their forehead, but they're just like, I can't stop shaking. I'm so cold. That's because now we know that they're not pumping that blood through the body like they should. Obviously, their blood pressure is going to be well below their normal range. We we want to know what normal blood pressures are. So when we go to check theirs is probably going to be super low. And the reason why is because the volume is not there. We're not getting the good volume exchange of blood like we want. So it's not going to have, you're not going to have that elevated or higher blood pressure. It's not moving. The viscosity of the blood at that time is more of a stagnant. It's kind of, I'm not going to say I don't want to say it's thick, because we're not going to be like, oh, you got thick blood. No, it's not moving like it should. That's the thing that we need to potentially keep in the back of our mind. Those signs that are telling us what's going on is because we're learning those signs and symptoms right now. Seeing your patients and listening to what they're telling you is going to be indicative for what you're visually seeing going on with your patients. What are we going to do for them? We're going to make them as comfortable as we can. I'm very big on bedside manner. Be very cautious and trying to tell them, this is what we want, this is how I want you to be, da 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 da. Be moving forward. It's okay, but we need to make sure that they feel like you're doing everything possible. We know that's right. We know it's there, but at the same time is listen to them. If they're telling you this or telling you that, that's cool, because that's exactly what's going on. We know that they're having that shortness of breath. We know that they need that oxygen. We know that the non-rebreather is going to be best for them, but the patient is not going to tolerate that. Obviously, for our advances and higher, we're going to start that IV. We want them to have some fluids going through them, and we want to be able to have that vascular access for any potential medication that we need to push later on. We know we're going to start transporting them to the closest facility, the closest and most appropriate facility. Some of the facilities may not be set up for, I was just catching up on the messages. So we know that those some facilities that we may run across are just not ready, and they're not able to be for a cardiac facility. Obviously, it says at the bottom, call for paramedic backup if available. If you're running an advanced truck or just a basic, transfer truck, you can still come across patients with this. You can get, as an advance, you can have everything ready for your paramedic interceptor to be able to pick you up and ride in with you and provide some more care on the way to the facility. Your basic trucks, obviously, you're not going to be able to start IVs and do things like that. But we can give them that oxygen. Call early if we feel that the patient is changing statuses on us. That's fine. We just need to know that so we can move forward. Calling early for help is not like screaming wolf. It's just saying, hey, I recognize something is wrong and we need to realize and move forward. So heart failure. So this occurs when the ventricular myocardium can no longer keep up with the return of flow of the blood from the arteria. Okay, so what's that mean to me? So this can occur time after MI, heart valve damage, or long-standing high blood pressure. So we talked about, Patricia said it earlier, taking that medication, doing those walks. Basically, those are things to try to help improve your cardiovascular system. And we know that trying to open that, help take these medicines that remove the plaque buildup that's inside of our vessels, can help improve that and potentially can get us some better times. Taking those yearly checkups, your heart checks that they push out, those are important to happen. Now, heart failure does normally happen between the first few hours and the first few days after an MI. So if somebody is on it, has been sent home from a recent MI, that is some of the history that is important for us to know. Asking those questions: have you recently been in a facility? Have you recently been discharged from any type of facility? Asking those questions will build that knowledge that we need to move forward. So that is a big thing. Building those good rapport, getting the good information, asking those questions is what's going to help us buy time to treat our patient in a better form. So let's talk about left-sided heart failure. So we know that their pumping function of the left ventricles are damaged, obviously because they're having some coronary issues. They may have a past history of some coronary artery disease. Those heart valves are damaged. So what are we going to do for that? So we're going to see at that time their heart rates increased. We should know at the time that left ventricle is enlarged at this point, and then that is producing a lot of blood flow that is being pumped per minute. So that's our minute volume. But again, the history that we ask our patients is very important. We know that this right here is also called the congestive heart failure because those lungs do start to become congested with the fluid that's built up that's in them. And with the fluid buildup, you're going to see the edema on their legs, their arms. They need to get some fluid off of them. And the reason why that heart fails is because it's just unable to pump the blood effectively at all. It is just not there. It's having trouble getting all that blood to the body and to the heart like we need it to. So now they have ultimately just gone into heart failure and they're dying in front of you. So asking the particular questions that can help our patients get better is amazing. We know that a good history, a good intake can build all that. So right-sided heart failure is because the heart is damaged also. And we know that the fluid collects there also. So you're going to have more so of fluid on the body than anywhere else. So if it's right-sided, you're going to have a lot of edema. You're probably going to have there's a certain way to describe it. Patricia, Rob, if y'all can think of the name, I just went blank. But we're going to see if we go to pushing on their feet or legs, you're going to see that pitting edema because now that swelling's there and we can't get it off as fast. We notice that pedal edema is especially when their feet and their lower legs start to swell. A lot of times these patients will be sitting with their feet up because they want to try to get that fluid to come on and off, but it's just continuously builds and builds and builds. No matter what we do or no matter what medicine they take, they can't get rid of that fluid. If you listen to them, you're probably going to hear that they're going to have fluid on their lungs. You're going to hear that the rails, you're going to see that they're on a buttload of medicine because of the fluid buildup that's going on. So knowing that in the background is something we have to figure out. Okay, what is it? Right side, left side? You're still going to have the edema. So it's kind of hard to figure that out. But if you notice that there's a lot of swelling in their lower limbs, majority of the time it is going to be right and left sided. A lot of these patients will complain it's painful. Their legs are so swollen that their skin hurts. It's true, because their skin does not, most of the time, it's stretched as far as it can be, and there's not much more that it can go. So that stretching is going to be very difficult. Some signs and symptoms. A lot of times the patients are agitated because any type of movement hurts. They may complain of some chest pains. You may see that they have a productive cough, and they constantly have these little napkins laying around, and they're coughing and they're spitting in the napkin. Be cautious at the same time, is because them doing that, you can also look at that. Depends if it's got, I hate to say it, but if it's a chunky sputum, that patient may particularly have TB also. So be cautious of that. You'll have that JVD and the distended neck veins. You'll notice these patients are using their accessory muscles in breathing. They're going to, majority of the time, be bent over trying to breathe to open their chest as much as they can. Or they will be a short and shallow breathing because they're trying to catch, they're always like they're behind and catching their breath. It's like me trying to run. I feel like I'm that type of shorter breath. So these patients are going to complain, no matter what they do, the home oxygen they're on, they just cannot get enough oxygen. What are we going to do for them? Biggest thing is we're going to give them that oxygen. We're going to give it to them through a non-rebreather. We're going to try their best to calm the patient and understand that breathing through this non-rebreather in their nose, out their mouth, is the best thing that we can do for them. Make sure you get a baseline set of vitals, because prolonging this, their vitals are going to start to increase. You're going to start noticing those rapid changing. You're going to have this to where the patients are going to change in front of you. So getting that baseline set of vitals is going to be the best. For our advances, we're going to try to get that IV access, and putting our patient in the best position is going to also help them, because they are going to be in a position of comfort. So they feel like what they're saying to you is being turned into, you're actually listening to them. But basically, we want them to be able to breathe on their own, and we don't want to have to do a whole lot of work. I mean, there are times that we have to do that, but if we can get them to maintain their oxygen levels on their own, that's the best thing we can. If we have that IV in place, it talks about administering NTG, that's nitroglycerin, but we're only going to give that if their blood pressure is above 100 millimeters of mercury. So if they're anything lower than that, we can't give that medicine, because you will notice a change in their blood pressure. So I don't like giving any types of medicine unless it's oral, like some baby aspirin or anything like that, unless I have an IV access. So me obtaining that IV access is most important to me before I give any sorts of medicine. That's just one of those things. I was burnt a long time ago. I did it and didn't have one, and I really needed it shortly after that. So having that IV access for the advances is to me, it's just as important as giving them that oxygen. Give them that oxygen first, and then go straight into starting your IV. So that's a Walley thing. So y'all have to excuse me on that. We'll go to 10 after 8 because I know I was a little late on this one, and then we'll take another break. All right, so pulmonary edema. So we talked about that. We know that that's because the fluid passes through the walls of the capillary and into the alveoli, so it swells. We know that common is going to be there. Obviously, without any type of treatment, our patients are going to go into acute respiratory failure and even death. So we need to act on that fast. That is where your CPAP, BiPAP works really well. It's pushing that fluid in them. It's helping them have open up their lungs as much as we can. They're able to breathe. It helps them out tremendous. I'm a huge fan of that. So if your service has that, pay attention, learn as much as you can. So when you're able to use that, it does the best things out there. When they're going through pulmonary edema, we know that they're going to have some complications of their myocardial ischemia. So expect that to be seen. And then it's saying participating causes include heart failure, myocardial infarction, pulmonary embolisms, hypertension, and cardiomegaly. So it's going to be, and I'll tell you, that's one thing I've always said. I wish we had more cardiology than anything else, because I feel like we just don't learn that as much, because there's so much that can go on. There's so much that can take place that we just feel like we don't have as much information out there. You're going to get to a point to where you're going to feel like I don't know what I'm doing. I don't feel like I have this. I don't have the information. I don't have the tools. I don't have all of this to take care of our patients the best way we can. But ultimately, we're going to do everything we can for them on the way to the facility, and then we're taking them to where they need to be, and they need to be at an advanced facility or advanced level of care to where they can treat them the most popular way. All right, so preload and afterload can greatly influence the buildup of pulmonary edema. Our treatments are going to be focused on maintaining the airway, some breathing circulation, and then transporting our patients to definitive care. So what are we doing? We're supplying them with some airway and breathing with some oxygen. Taking those blood pressures, we're hoping that we can improve their circulation with that IV, flowing at a TKO rate, or either wide open, depending on their blood pressures. We're trying to help them with that, because we know that their blood is thicker because they're not able to move the blood like they should. So that's a lot of things that we can do when we're going and during our transport. So hypertension. So hypertension is any systolic blood pressure that is greater than 140 or a diastolic pressure greater than 90. So I would know that one. So this only occurs when the systolic pressure is greater than 180 and a rapid increase in the systolic or diastolic pressure of 120. Some of the signs and symptoms you may see, you may have some sudden severe headache is very common, some nosebleeds, some weakness. You may have some syncope that's in there. Easiest thing we can do is put the patient with their head elevated. We can, again, try to let them relax, calm down, transporting them in a position of comfort. Again, don't put them, we don't want to put them in the Trendelenburg position with their feet up and their head down, because now they're having this rush of blood. Big thing for our advances is obviously our IV access that's going in there. And when it talks about monitoring their blood pressure at the bottom, we want to do that on the regular. We know for our trauma and medical patients, we're going to do 5 minutes and 10 minutes. But on these particular patients that are actually going through a hypertensive crisis, I'm going to keep monitoring them at a 5-minute rate. I'm just going to let it sit at the monitor every 5 minutes. I want to know what their blood pressure is, because we will actually see those changes going on in front of our face. So a good accurate blood pressure is key here, because they may tell you, hey, I'm on some medicine. I'm going back and forth to figure out what's working the best. I just don't feel good. You will notice that their blood pressure will be 1 second. So if you do it seated and you go to stand them and you notice a good change that's greater than 10, we know that they're obviously they're having some blood flow problems. But again, you may notice also that patient becomes very lightheaded. They will get dizzy. It's because they have a very large orthostatic change in their blood pressures. We'll go over this one and then and maybe another one or two, and we'll get that break. All right, so aortic descending aneurysm, the easiest thing I can tell you about that, be very, very cautious with your patients. Don't move them in a hurry. Don't rush them. Don't bounce them. Don't hit any bumps. because at any point in time that can rupture and they will literally die in the back of your ambulance. Because I say that you weren't soft and sweet with them, and the reason why is you're a little bumpy, you're a little rough with this patient, because they're basically like that valve is fixing to rupture, and there's nothing we can do about it. They need to be on a table. They need to be treated by having surgery, and a lot of times that is they can die on the table from these. So be cautious of that. An uncontrolled blood pressure can be, and majority of the time, is the cause of this uh, dissecting aneurysm. Mm, yes, that is correct. They will have that sensation of tearing that just happens. They'll tell you, I feel like, like I feel like it's tearing. I don't know. Like I feel like this. I feel I had a rupture. And when anytime that they say that they felt that, it's kind of like, what did you say? But again, when we move them, let's be as very careful, cautious as we can with our patients because of those complaints. That's something that we have to be cautious for. We have to know what's going on in the back of our mind, because hey, they've said this. I'm not real sure, but I feel like things are not going the best way that they could, and I feel like they're gonna die. Well, probably so, but let's be cautious with our patients that have that any complaint of that tearing. They have that sudden chest pain that's within their chest or their back, because that's where they feel those particular pains, and that tear has taken place. All right, our assessments. No matter what the patient says, we're going to do a very thorough assessment. We're going to take what they say as $1,000,000, but we want to get all of the information, because I don't know them. And even if I do know them, I don't know their history. But we need to make sure that we listen to them. Uh, Patricia says, I don't know who can see it if y'all are watching this later on. Do not palpate a pulsating bulge in the abdomen. It's not pretty to watch. That is very, whew. It was, Patricia saying it's not her, but we all know what that means. So basically, we want to, if you see this bulging and it looks like it's got a pulse, don't touch it. Let it be. Let it do its thing. On all of our assessments, we're still going to do our scene size up. This is not changing from call to call to call. We're going to continue to do this, do this, this. We're going to march it down. Just because you see that bulging pulseless knot in their abdomen, don't let your blinders be on. Remember, don't fixate on that special item, but look for all those other signs and symptoms as you're walking up to the patient. What does the house look like? Is it safe? Do we see anything that's going to hurt us? I like to introduce myself as I'm coming in through the door, and the reason why is if they're able to respond to me, I can tell. I'll be like, wow, it took them a minute to get those. Hey, it's me, because they're having some respiratory problems. We know that our primary survey, our scene size up, we're recognizing a lot of those potential hazards that are there. On your primary survey, obviously we know that we're going to get that general impression, and I like to tell everybody, if they look like poo, they probably feel like it. If they have that whitish gray appearance to them, they're not in good shape at all. Remember, don't get accustomed to doing the least thing you can inside the house and get out to your ambulance and it's a safe zone. Granted, I know that, but I'm a very big stickler. I take everything inside the home on every single call. On transfers, I take my monitor, I take my bag, and I take oxygen. That's just something that, to where if I can be in the elevator stops or breaks, and I have this patient and they turn south, I'm able to see that, and I don't look like a dummy when the door opens and I'm like, well, they died. I was in here 10 minutes. I didn't have my stuff. looks bad. So no matter the call, no matter the situation, always take everything that you have with you. I'm gonna get to these next 2 slides, and then I promise you we'll take a break. All right. So obviously we know we're going to do the head to foot scan, the front to back if possible. We're going to look for any of those major bleedings. We don't see anything, or we do. What does their lower limbs look like? Do they have that edema that we spoke about? And I know how it says on the bottom when it says consider the use of CPAP when needed. Advances. That is something that I'm a huge believer in that. When my mom was on the end stages of her cancer, we did call for a hospital. I mean, an ambulance to take her to the hospital. She was having trouble breathing. I knew what she needed. A very good friend of mine transported her for her last time, and put her on CPAP, and instantly she changed. And we noticed that as we were preparing her, get her ready in the back of the ambulance. And he looked at me and he said, "Wally, you ready to go?" I, I knew at that point I needed to be a son versus like a caregiver. So you will see those things take place with these patients. The use of CPAP, that high forced in oxygen, is very, very worth it. Um, but fair warning, if you started in the house and you know you got about a 10-15 minute walk with that patient, your one regular oxygen tank ain't gonna last you. It's gonna run out pretty fast. So that's the downfall of CPAP, is if you're not using that and you're inside the ambulance on your big tanks. After assessing their airway and breathing, assess the patient's circulation. We can do that from a distance. We can actually see, are they breathing, they talking, because we know you got to have some circulation to be able to talk. You know you got to have air coming in and out to talk. What do they look like? What's their color, their moisture? Obviously, we can't tell a temperature across the room, but we can, when we walk up to them, we go to introduce ourselves. We can reach our hands out. Do they have the cognitive skill to reach out and grab your hand and take that introduction? And when they do that, I like to, you can assess their hand, shake their hand, put your other hand on their forearm. That'll give you an idea what their temperature is. Be cautious when it says about your capillary refill time, because we know that a lot of times it is not as accurate as we would like. If they have any type of fingernail polish on there and you go to put your pulse ox on there, it's not accurate, because now you got to get through the color, you got to get through the coating down to that's in the fingers. So when you do that little finger pinch test, be cautious. Your runners are going to have a slower refill time because they are used to running off of a lower intake. When it talks about making a transport decision based on whether you're able to stabilize life threats during the primary survey, that as you walk through the door, again, hey, he looks bad. We know that. We know that we need to load and go. We're not going to stay on scene and do any type of plating. So that being said up front, understand that it's going to be time. It's going to be time to go. Let's get them going now. Be cautious on that tearing sensation, that bulge in their abdomen. Be very cautious on that. We need to load and go, but let's do that very calmly, collectively, and moving forward. So I show 15 after, roughly 20-ish more slides. So let's take a 10-minute break. We'll come back at 8:20 and we'll wrap it up. So see y'all in 10 minutes. Okay, so talked about a primary survey. All right, so history taking. We want to build as much information as we can about this patient. Remember, all of our patients normally are going to be strangers to us. If you work in the area you live in, you're probably going to know folks that you take care of. Or you're going to know somebody that knows somebody. Remember, be careful also of your HIPAA. They're like, hey, didn't I see you at the call the other day at Mike's house? Yeah, well, what's going on with Mike? he just wasn't feeling well. We have to be careful about that. Sorry, that's my little tantrum there. When we're building our history, ask those questions that are sometimes difficult to the patients. It's going to you, but at the same time as we don't know. Ladies, I'll tell you straight up, I always assume that ladies are pregnant until I can be proven otherwise. Now, granted, some people are like, I had a hysterectomy 15 years ago. Oh, you're right. You're so right. But until I know, we have to be cautious of that. We're going to be very professional when we ask these questions. Um, but there's sometimes we may have to ask those questions that are just not favorable. Like prime example, Rob and Patricia know this. I don't like teaching OB. I feel that if I teach something, I need to know it and or experience it. Well, I know about OB, but I can't tell you what it feels like. I've had children, yes, but I ain't I didn't bring them into this world. So we're asking these questions so I can basically write a book about them because I'm going to write my report. So building your history taking is very important. Um, I always like to say, in the last 10 years, to a have you been admitted to a hospital for any reason? Have you had any surgeries in the last 10 years? Because 10 years is going to be, it's going to be a good broad range. It's going to give us our knowledge base. It's going to give us the information we need to know. Granted, now some of it may not be, like men. Well, I got fixed when I was 15. Well, bro, you're 55. That doesn't count. Some of those things that may not build up to where we're doing right now, or that we're taking care of our patient. So be cautious when you ask these questions, because you're probably going to hear some stuff that you may not want to, you can't take them back. There's no take backs in asking your history questions on your patients. Ask them about their signs and symptoms. Tell me what's going on. Why did you decide to call at 2:30 in the morning versus 8 o'clock last night when all this pain started? And you're not being ugly about it. It's just what has changed from when it started to right now. Now remember our sample. That would be our signs. Remember to ask those sample questions. Break those down. I love the sample acronym. I'm a big acronym guy, so if it's one of those that helps me out, that's amazing. Now remember, when we talk about allergies specific to medications, a lot of people will tell us that they're allergic to morphine. Okay, tell me what morphine does. Well, it makes me itch. I know that. I, Sorry, I was reading Sandy's note. I know that that is a side effect of morphine, not a it's not an allergic reaction. So we need to know these informations about medication, because if we, like prime example, me with penicillin, I quit breathing with it. It's a great drug. I just quit breathing. They The medical doctors have told me that is unheard of. Well, okay, well, don't give it to me, but trust me, I have been there. I know when I woke up, they told me that you quit breathing when we gave you the penicillin. Okay, well, I don't want no more. I take that as a life or death issue. So asking those questions about your medication allergies. Now in your books, it will also tell you about the OPQRST, and then they've added I into there. Those questions are just as important when you're building a history. That will give you a very good range of information to obtain from your patient as you're asking this history information. So it's very important to build this vast little knowledge that we're having, because remember, you got to sit down and write this book about them. Before you can clear that call, you better at least have enough information to be able to write your report. Because 7 calls later, you're gonna be like, man, did this guy tell me he was a? Oh man, I don't remember. I'm still the old school fanatic that I like my 2-inch tape. Each person gets a piece of 2-inch tape, and I write everything down with a Sharpie on that 2-inch tape. Now I take it and stick it to the dash. That way, and I put my run number or whatever y'all have it. So when I go back, I have my notes to look at. Because no, a lot of us aren't able to finish our reports and stuff by the time that we get to a facility. So we all have to go back, or we've been pulled out due to a heavy system. So taking that tape, sticking it to us, writing all that information down, later on, even when you go into the hospital, the nurse is going to ask a question when they're receiving. You're like, oh yeah, I remember that. Hang on, let me look. You pull that piece of tape off, you stick it on your arm, and you read it. That is that's your cliff notes of your patient. I'm a huge believer into that, because I will lose a piece of paper in a heartbeat. I'll ball it up and throw it away with everything else. But that tape it's one of those, stick it to your leg, and then when you're done, you're going to know you're going to get back in the front of the seat of the truck, stick it on the dash. You're not passing, let's say a family member of another patient gets in the front, you're not passing on HIPAA information, because they'd have no idea who that was. So to me, that was always one of those, I ain't been on a truck in a minute, but you should see me when I'm offshore. I have a big whiteboard back there, and I write all over that whiteboard. That is my piece of tape, because I'm the only one in there, so I'm the only one who's going to erase it. I'll turn around and look at that board, or leave it up there for a day or so as I'm writing the report, just so I have my information. And then offshore, each patient that I gets a color. So I start at the top of our dry erase markers, and that's the way I work them down. Because I know if I get 2 or 3 patients in a day, each one's a different color. So weird thing, I know, that's just my little side notes. All right, so on our secondary assessments, we know we're going to do that rapid head to toe scan. But on your secondary assessment, we're still going to do that rapid assessment. But now we got time. Well, majority of our patients, we're going to have time to touch every limb, the head, the neck, the chest. Be cautious, men. But we're trying to, obviously, if it's just a broke down medical patient, we're not going to be looking for those fractures, or we're going to tailor those assessments to those areas. But remember, you still need to, let's say the person accidentally had a stroke, they slipped, tripped, and fell, and then they did break their leg. Okay, I'm going to check everything, but now I'm going to make sure that quick, rapid assessment, I did splint the leg, I did feel a pulse. Now in my secondary assessment, I still have that pulse. Once I feel for that pulse, I'm going to mark it. I'm going to take that the marker, I'm going to write on them, pulse with an X. Those things help you. You're going to check their level of consciousness. Have they changed? Are they changing? Do we visually see this? It is 100% fine for you to start a transfer, start a transport, no lights, no sirens. During the transport, you realize, whoa, this patient has changed fast. We need to upgrade. Let your people know that, answer the radio, you're upgrading this call. That's your decision, your everything. So nobody can come back later on and be like, I don't know why you did that. I wouldn't have done it. Well, that's right. You are not me. I made that decision based off of what I know. Keep a very, I don't want to say like a journal of their vital signs, but you need to know, at least if you're checking them every 10 minutes, you need at least a good 3, 4, 5 vitals during your transport. Yeah, some systems require you to add them multiples and the times. Some of them may auto-populate between the monitor and your computer because they're Bluetoothed in. So the more you have, the more it shows, and truthfully, it will show that you did the right thing at the right time, checking those blood pressures, making sure that they're within range. Or, I know it talks about obtaining a blood pressure reading in both arms to compare for a stroke or aortic aneurysms. I don't always do that. I will check them seated and standing. it's just one of those things that I don't. It is a very good thing to do. If let's say you have two cuffs and you can unplug one, plug in the other one back and forth. But honestly, as much as going on in the back of that truck, trying to remember, oh God, I got to unplug it and plug it back up. Those things are some of the things that we just have to make sure we do. If we suspect that stroke, check them twice. If you only got one, you can be undoing it and hooking it back up pretty regular. And you note that is, hey, I had a good orthostatic change from left arm to right arm. Did I notice any deficits? Was the patient having, affected versus this side even more than the other side? Well, then now you know that may be because of the stroke. On our reassessments, we are checking the things that we've done. Advances, if we started that IV and we have it set at a TKO rate, that means to keep the vein open, we're going to go back and just make sure that there's no occlusions in there. You still have the correct rate flowing. You're going to have the right amount of drops you want, and there's no swelling in the arm from your IV. IV may be infiltrated, or it may have bleeding into the pleural space, or filling into the pleural space. Basics, when we're doing this, if you do anything to the patient, you need to go back and make sure during your reassessment that it is still the same thing you recorded it after you did it the initial time. So if I set their leg and their pain level dropped tremendously, we want to make sure that their pain is still manageable. Yes, we call for an intercept, the medic's on its way, or maybe an advance in whatever area you're in. We're just checking the things that we've done. We've provided them with oxygen. Hey, sir, I just want to double check with you. How's your shortness of breath? Has it gotten any better or any worse? Note that change. Hey, on a scale of 1 to 10, 10 being the worst pain you in, are you still, at the initial rate? What would you rate your pain now? Or word that question to where it's more of an open question versus trying to say, hey, is it still at a 6? Well, yeah, it is. I just gave you 50 of fentanyl. You shouldn't fill your lips. Those things that we want to make sure is there. We're going back to chart that. When you give your hospital report, this is a pet peeve of mine. You gotta give your report 20 words or less. 37-year-old male coming in with chest pains, give you full report on a rattle, IV established at a TKO rate, shortness of, O2 at 15 liters a minute. Keep it short, the simple method. Keep it simple, stupid. The reason why is, honestly, those nurses ain't listening to you after 20 words. They don't want to hear the whole dissertation, and you're tying up the radio for everybody else to try to do a report. That's a pet peeve if you didn't notice that. So when you're giving those reports, though, make them a good, accurate report, but keep it short, because they're going to turn around and be like, all right, hey, we got a guy coming in with chest pains. That's all they know. Okay, they're going to do this, such and such. They're doing it their way. Just remember to give them enough information to keep going. My notes here say, if cardiac arrest occurs, you must be ready to begin automated defibrillation or chest compressions immediately. I wish we had automated the automated CPR machines, whatever they are, whatever they're called, offshore. They're expensive. I know money's no option when you talk about safety. Some services have those on every trucks. Your particular service may have it, but they may have it on certain ones. So yeah, that's it. The Lucas device. Thank you. So they're great. They're phenomenal. Some services may only have it on your advanced or your ALS trucks. Some services may have it on all of them. They're phenomenal. But remember, you're going to wear out pretty fast trying to do CPR on the way to the hospital. Basics, if you have your AED and you've applied it, just let the facility know. Advances, if you're coming in, you've done, your 4 leads and all that other information, just pass it on to them. Let them know, hey, look, I got this patient on the monitor. I'm seeing such and such rate, and he's in a sinus tach rhythm. If you don't know the rhythm, we need to make sure we study up on those cardiac rhythms. Those are super important to recognize. Emergency, what am I? Treatment for the patient begins with proper positioning. We talked about that. Put your patient in the position of comfort. If your patient is talking 900 words a minute, but they say they're shortness of breath, oxygen is the cheapest thing you have on your truck. It's cheaper than diesel fuel. Give it to them. Period. Just leave it like that. If they're like, oh, that's so much better. Sir, you're in a nasal cannula at 2 liters per minute. And you're telling me instantly, and, in the back of my mind, I want to be like, let's do some math here. Do you realize how much oxygen you're getting? I do that all the time for your home patients that you pick up, and they're on 50 feet of O2 tubing, and it's set at 2 to 3 liters a minute at home. Let's do some friction math there real quick. How much do you really think that they're getting? I will put a patient on a nasal cannula. I'll check their pulse ox while I'm inside their home, and then I'll put them on a nasal cannula. Not all the time. I will hook them up initially because I want to see what their base SpO2 is versus what they're on at 1 to 2 liters on a 3-foot hose. I'm not depriving the patient of anything. I'll hook it up to the tank. I'll have everything ready. I just won't turn it on until I get a base set. That's giving me my baseline vitals. So I know, hey, on a normal, the patient's breathing at 96 times a minute, 96%. Now, I am not saying that is 100% correct way, but I have a base. At 2 liters, they go up to 97%. So there we go. Patient who is unresponsive or in obvious respiratory distress, you may need assistance for them to be breathing using a bag valve mask or a positive pressure ventilation device. Obviously, we know if we're having to bag somebody that is conscious, it is very difficult because you got a time squeezing of the bag with their inspiration. I will try to tell y'all this. When you go to lab, try to bag yourself or have somebody bag you as you're sitting there with some of your other students. And the reason why you will meet that resistance because they're going to be breathing out when you're trying to push the bag in. It's difficult. You've got to get your timing right. And for a patient that's having shortness of breath or they're in that distress, you're putting this mask over their face and they think they're fisting the fly. An F-17, bro, I can't breathe. And you're trying to put this over my face. So knowing that up front that and how hard it is versus all those things will help you understand. Advances, we talk about again in that IV access as long as it doesn't cause any delay in our transport. We're not going to say, oh, I need to stay, we need to stay right here until I get the IV. Do it going down the road. I still to this day can't start an IV without moving. It is so much better for me if our platform is shaking side to, no, I was not say shaking, but if it's moving a degree left or right, that's so much easier for me. I have the hardest time starting IVs being still. It's hard. Like my wife or my kids are sick. I have to move. I have to move my hand. I have to bob. I have to feel like, oh, bump's coming, and you hold off, and then you stick right after the bump. It's one of those. It is so hard. Do not get used to having to always start your IVs being steel advances. I'm telling you, that is the worst thing that you can do. What's this say? Nitroglycerin, we talked about that. We know that those are phenomenal. Make sure you give them their aspirin and that nitrogen as long as their blood pressure is above 100. Basics, I encourage you to question your partners. Obviously, don't be ugly about it, but when you do, why did you do this at this time versus doing it this time? Ask those questions to help you learn to make you better. So when you come back through our class and program as an advance, you feel you have that one step up. You have that leg that's already been out there, and you're all right. I understand more of what they're talking about. So the reason why nitroglycerin works so much, we do know that it does, it helps relieve the pain of that angina. Another thing that's very big that we like to say is if that nitroglycerin causes them to have a severe headache, it's not cardiac related. If it doesn't cause them to have a headache, it is cardiac related. So that's the reason why I tell you, start your IV first, then give the medication. I always tell them, hey, I got to get this line started real quick before I give you any kind of medications. So work with me. Don't jerk, don't move, don't yank your arm from me, because I'm poking you with a needle. So that is very big things in my head. I also do a blood sugar check every time I start an IV. It doesn't matter if our patient is having any type of sugar problems. It's one of those that it's always good to have that information. They could have some of that low sugar or high sugar. We don't know. We got to find that out. We talked about nitroglycerin. Make sure that it is in your standing protocols to give. If you have to reach out and obtain verbal orders, make sure you do whatever your service requires or that whatever they suggest. The reason why is you don't want to do anything that you're like, oh, well, I know where they were going to ask. But again, you went out on your own and did this without having orders for that. So whatever your service tells you to do, make sure you follow those protocols and any type of administering. Always, 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 anytime you give any type of medication, it doesn't matter if it is any type of like oral medications, make sure you wear your gloves. The liquid nitrogen is great, so is the pill form. But on the pill form, any of that dust that gets off can get into your hands. So having the gloves on will also help prevent that. Heart surgeries or any type of cardiovascular devices that have been put in there, we will see that wonderful scar down their chest, like we always have seen. A lot of times your patients will tell you that they feel like their skin is tearing or they have like this tear sensation in their chest. Asking those good questions will tell you, hey, has this person had surgery like this or is it a tear? Because if this is a fresh tear, a fresh cut from throat to belly button, we know that this is from that particular pain. As you can see, this person here has also had some gallbladder surgery. Those are instead of doing laparoscopic these days, that's how they used to cut you. So you may have some coronary artery bypass grafts. I'm sorry, my dogs have decided to act up. I know y'all hear that. So coronary artery bypass graft is a blood vessels from the chest or leg that is sewn directly into the aorta. So you will notice that they will have a some type of surgery or scar on their legs where they've moved that, and they have turned around and placed that into the heart. Chest pain in a patient who has undergone any of the procedures should be treated the same as chest pains in a patient who has not undergone those surgeries. So it doesn't matter if it's taken well, if it hasn't taken well, we're still treating them that they're having those cardiac pains and that discomfort that we're going to work on and take care of. We have these cardiac assistance devices. You may have your pacemakers. A lot of times, I'm going to skip and show y'all. So right here, you'll notice a lot of the times they will be in the chest. There is, for a while, one of our facilities up here in Jackson was doing them to where they were putting them in the waist, abdomen, flank area. I haven't been around a facility in a while that still does that, but majority of the time they will be into their upper left chest. Now, those batteries sometimes do have, they will die. They have to go in there and replace them. So they may have had some, a battery replacement. There is a particular type of magnet that will also go over these that will stop them into once they get into the facilities. But if these placements of these devices actually shocks the heart, know that in advance, because if your patient goes into a certain rhythm and they start getting those electrical shocks, it will scare you. I'm just letting you know. I actually told a patient, I was like, "Would you quit jumping?" Well, it wasn't him. He was getting shocked. So just know that. Um, Make sure when you put those pads on those patients that you don't put the pad over that area, which you shouldn't anyway. Should go right chest and under the left breast, not over the left chest. So make sure you look at the pictures that are on there. We all do really good with pictures, so make sure that they're put on right. I don't see these as much as the defibrillator vest. I don't know if y'all have some in your particular areas. This used to be something that was um, big in the start of putting in those devices, but basically it's a vest that the vest will tell you what's going on. It tells you the voice prompts. It tells you if they're going into any type of dangerous rhythms that's going to create a shock. It'll tell the patient lay down, sit in a seated position, or it may be sit in a seated position and or lay down. Um, you don't see them as much, or if they do have them, they will be having heart surgery within the few days. So those are some of those. You have your LVADs. LVADs are very cool, but if you do have those LVADs, make sure you're right. They are pretty weird. So an LVAD, your patients are going to know way more about them than we think we even could try. So if you have a patient that has an LVAD at all, even don't matter if you're transporting them home or you go to their home for somebody else, and it is not a critical condition, ask that patient, hey, do you mind? Will you take a minute and just tell me about your LVAD? Just ask those questions, simple little questions. Just say, hey, what about this? What about that? Just let them teach you because they know the ins and outs of their own systems. Yes, and the family is also trained on them too. So it is like one of those pre-things that the family members that are going to be living directly with them have to attend these classes. It is just an educational. This is how it works. This is what's going on. Blah 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 blah. They'll tell you what happens if the battery goes down, or they're always close to some charging devices. They have cords. They have a lot of batteries. So LVADs are freaking cool. Um, there's also a big print number to call in case of emergency. I've dealt with 3 LVADs in my time, and I learned more from those patients than I have ever. I was like, I feel like I should have recorded this conversation because I don't even remember your name. They're amazing. So your patients will tell you every single thing that you need to know, and or their families. All right, so cardiac arrest. Obviously, cardiac arrest is the absence of a pulse. Done. Basically, this can be from a medical event or it could be from a trauma event. Doesn't matter. We're going to treat them the same. We're going to make sure that we know the ins and outs. We're going to do CPR, all that stuff the same exact way. Having your AEDs close to you guys, basics, make sure that they power on, the batteries are good. Both of those, I have used those and talked with those through my time. They tell you everything that you need to do. Your advances and going into paramedic, specifically on a life pack. I can speak. The life pack has an AED mode. During our cardiac arrest that I've had on the platform, I had so much going on, and I had so many first responders that are out there with me that I actually put it in the AED mode. And the reason why is because I was so busy and I didn't have the time or resources to tell them every single thing I needed them to do. So I told the doc, I said, hey, I've done this. This is why you hear it in the background talking to him, is because I got some other stuff that's going on. He's like, dude, I never even thought about telling somebody to put it in AED mode. I was able to intubate the patient. I was able to start another IV on this guy. So I had 2 flowing IVs by the time the helicopter got there. Obviously, they were all turned off and everything was left in place because he passed before they made it. But having that ability to push the button and let them just listen to it is great. Getting used to that and getting out of that situation is what we need to make sure that we're not dependent upon that A&D mode advances and moving into your advanced and also paramedic. As you read there, the AED is only shock in the monophasic and biphasic ends. Monophasic sends energy in one direction, biphasic sends energy in 2 directions. Knowing the difference, basic and advances, that is very big because you may see some questions. What's the difference between monophasic and biophasic? A, B, C, or D, whichever one's right, that you need to make sure that they don't swap it on you. Be like biphasic is in one direction. Well, it says bi, which bi is 2, and then mono, you have that 1. So that's knowing the 2 differences there will tremendously help you out so that I'll let you know which one does what. There are some really good advantages of AEDs. We know that a lot of your industries have them inside their plants. Malls have them. Obviously, your hospitals do in certain parts of the area. Clinics are starting to get into them. Think about churches. A lot of your bigger churches, not going into your mega churches or anything, but a lot of your religious facilities are going into that to where they're also purchasing those also, so they have them for the community or for the attendees. Obviously, we know the 5 links of survival. That's coming up because we went over that in our CPR class. Recognizing immediate CPR, rapid defibrillation, basic and advanced EMS care, and then ALS and post-arrest care. I remember when we were going through the phase of lowering the patient's temperature, we used to keep some instant ice boxes. Really, they were just coolers on our ambulance where if we had a cardiac arrest syndrome, we would start them on a normal bag, but we would change them over into a cold bag, trying to drop their temperature so it wouldn't cause as much brain damage. They've gotten away from that now. We just use the old bag out the bag, and that's kind of where they've stuck. There's your chain of survival. We should all know that from our basic class. Let's see here. Integration to AED into the CPR. We know when it says stand clear, we don't want anybody touching. If you're in charge of the AED or you're in charge of delivering that shock, it is your job to make sure that everybody's clear, that you make sure nobody's touching them, because one is their heart rhythm may potentially come through there, or if they get a shock, they will also be shocked. The ARES are normally, we didn't plug them in correctly, or there's still some movement. You may have some vibration or something that's causing that, and it may tell you no shock advised. But once you realize that, you give that good surrounding area look, check that, make sure that it is fixed. I do always like, once I put them on there and I'm using the AED, I make sure there's no frays in the cords. It's a quick thing. I'm just running my fingers down through those cords. I don't feel any frays, anything like that. Most of your AEDs come with 2 sets of pads. Sometimes, depends on your patient. These men that are particularly hairy chested, you may have to put 1 pad on there, rip it off so you can move the hair so it makes that better contact. Because not having good contact, yes, it can cause some inability to deliver a shock. You're not going to set fire to the patient's chest hair, but I have in the past smelt some burnt chest hairs, and the reason why is we were still back in the old Stone Age, still using those paddles. You just didn't have enough conductivity or the lube that we've had to put on there to make the connectors, the proper placement of those manual ones. Those are the good old days, and those used to be fun. CPR, we talked about that. Push hard, push fast, ensure proper recoils. Don't hold enough pressure on the chest where you're not getting that full recoil. Make sure that you're You notify somebody pretty fast. If you're by yourself, you do 2 minutes of CPR, and then you leave and go call for an adult. Or sorry, it's backwards. It's for a child. An adult you call first, and then go back. So follow your BLS for your CPR anytime it comes into performing CPR. Defib, prepare with standard precautions en route to the scene. Maybe you're at the mall, you're maybe touring a facility, something happens. You know what's going on. If you give access or you give your help, make sure everything's done right. Once the pads are put in place, you start CPR right back. You try not to have any delay in the use of that. So when you're using those, put them on. You can put them on when somebody's still doing CPR. You don't have to stop. All that will build over time. You'll get used to that as you're going out there and doing it in the field. Biggest thing here is the first keyword there is follow your local protocols. That is the biggest thing that I need y'all to understand is follow what your protocols say. Let's see. Patients who do not regain a pulse on the scene of a cardiac arrest are usually do not survive. We need to make sure that you follow what your protocols say. A lot of times is once you start ALS care, advances in paramedics, you will make sure you have to continue that care until you're either told to stop by a physician, or it is a situation to where you are unable to perform CPR anymore. If it's just the two of you and you are just worn slap out, you've done everything you can as long as you can, and you cannot go any further. If you transport a patient while performing CPR, you need to make sure you have a plan for treating the patient in the back of an ambulance. If I'm not mistaken, Acadian, so if somebody knows better, if Acadian, if their patient goes into cardiac arrest during transport, they do pull over. For both care providers get in the back of the unit. They provide that care on the side of the road. There's a time clock that they basically follow that walks them through the certain procedures and steps of their protocols for CPR. There's your algorithm for cardiac arrest. A lot of your services are really big into algorithms that kind of walks you through it. You will see these in a lot of your protocols. I'm a big fan of algorithms that kind of understands, okay, yes, I've had circulation. Yes. Okay. No more circulation. Then you begin chest compression. So those things, they're great. They help you walk through your particular case or give you a broad range of what's going on. Cardiac arrest during the transport, obviously, you're going to start CPR immediately. You're going to make sure that you know to analyze what rhythm and rate that they are in. If it does tell you to deliver a shock, again, make sure that they're not touching the stretcher. The old days, they used to have metal stretchers and sides. So you would make sure that you and/or your rider in the back were not touching the metal stretchers. I know your strikers and all that are all metal at the bases, and they have plastic sides. It's different. We still had to do it all manual back in my days. No, I'm just kidding. No, seriously, we did. It sucked. But nowadays you have the footings and all that. So just be cautious of that. You're going to make sure you deliver that shock, continue resuscitation based on your local protocols. Again, the biggest thing is you never want to delay CPR for any reason that is under your control. Here it tells you right here, check for a pulse, stop the vehicle if no pulse is present. If the AED is not immediately ready, perform CPR until it's ready. So that's kind of the reason why Acadian has that in their protocols. And so there's two attendees at the same time to do that. So I love when fire departments are like, hey, do you need a rider? Well, hell yeah, come on in, boys. The more the merrier. That's just my opinion. It makes it easier in your life if that is something that that you're down for, they're like, oh, we'll send somebody to pick them up. Heck yes, I love it. I'll never turn down somebody else who wants to help. Um, let's see here. So beginning compressions and continue resuscitation according to your local protocols. And this does include transporting of the patient. So once you start during transport, you want to make sure that you continue that all the way through your transport, and let the receiving facility know, hey, CPR is in progress, and da 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 da. We will, if there's available, we'll need some assistance out back. Some of your other services and even your service can hear that over your hospital net if y'all still using radios, and you may do it by cell phones, and they'll be there to help you. If your other services or even your own will be in the back, kind of help you get out. Some facilities will also allow their staff to come help you get out of the back of the truck. I know some hospitals also have that. Hey, we can't go out and get them out. That's where the ambulance. It's weird when you go from different facilities that receiving your patients. So the management of any type of spontaneous circulation. So if you have the return of that spontaneous circulation, make sure that you feel different areas for their pulses. Make sure you check the radial. Make sure you check the carotid so that you are receiving the same thing. I do have a carotid pulse. I do have a radial pulse. You want to make sure that you do still provide that back valve mask that you started. And the reason why you still want to give them that respiration, you still want them to get to 96 to 97% on their own, but we want to assist them. So that 10 to 12 breaths a minute that's maintained on their own, that's very, very important. You're going to make sure that you do have a return of that blood pressure. So now that the patient's starting to come around and they're able to follow commands, you literally feel like you won the race. I mean, because having a patient that was complete unresponsive, you've done all your care, your cardiac arrest care, and now they're breathing and talking on their own. It's amazing. I've had it once in my career. I've had to extubate the same person. So once I put the tube down, I ended up having to remove the tube because their gag reflexes kicked in. It was amazing. Now, the patient didn't survive greater than, I think it was like 4 days, but it was that ability that I actually did something. You still have to transport this patient no matter what they say, because you started advanced care, even as a basics. That is an advanced care, doing CPR, the bag valve mask. We still need to take them to the facility and say, hey, why did this happen? What's going on? We need to know the ins and outs of what caused them to go into cardiac arrest. As you see right here, depending upon your protocols, some advances are allowed to attach a 4-lead. So when you do a 4-lead, here's your placement. I always like to remind everybody, and by no means I'm picking on anybody, but you do white on right, smoke over fire, and green is neutral. Some people tell you salt, pepper, ketchup, whatever figurations that you come up with, but white on right, smoke over fire, and it does. The best way to get it is shoulder, abdomen's area. Those are the best way that it tells you to get a rhythm. I have put them on the wrist and the legs. I've put them on the chest. Yes, that I still get the same results, but this right here is the best way for you to get a good ECG. Just to show y'all how the 12 lead goes. So the 12 lead goes, so you'll still keep your 4 leads in place. You'll have your V1 through V6, and those start always on the patient's right side. This will be V1, and this straight across from that is V2. And then 3, 4, 5, and 6, they basically cup the breast area of your patient. Male or female, it doesn't matter. If it's a female, make sure that when you're applying these, that you use the back side of your hand. Same thing for women, because this is allowing us to see a very accurate 12 lead of our patients. So once you place this right here underneath the breast, you can allow, if it's a female, for the breast to come back down. For the men, you want to make sure you go right underneath here where their breast, like their breast is, and that gives us. You can see here's the what the leads are doing and what you're actually viewing. Even through paramedic school, I never answered those questions. What, V3 sees the anterior wall of the left ventricle. I know what it does, but I was never asked that on a test. That is something for us to know. So when you're looking at these 12 lead sheets, even for your partners to show you the information, it's helpful to know what you're looking at and where you're looking. It gives you a better idea of what's going on. All right, so I've had y'all bored long enough. Guys, that is the end of our presentation tonight. I want to thank Patricia. I thank Rob for all stepping in, keeping things live. I appreciate y'all keeping everything going for this evening. Does anyone have any questions, concerns, or anything like that? All right. Well, if nobody has any questions, I'm going to mute my mic. I'm going to stop sharing everything. I will sit here in the dark. And if y'all don't have any questions or anything, y'all have a good night and see y'all again Monday night. Y'all have a good one.